Next, we're going to go to Glenn Kraft, who will join us to discuss a forensic review of charge capture. Glenn founded G2N in 2001, recognizing that there's a challenge facing providers for proper payment. Glenn has been successful at recruiting smart employees who are motivated to achieve new heights. Developing his employees and supplying practical solutions for clients continues to improve G2N services. As a former regional VP and CFO for Tenet Healthcare and CFO for SSM Healthcare, Glenn is committed to providing exceptional and practical solutions with a solid financial return on investment while serving as a continuous partner to G2N's clients. When Glenn is not running G2N, he can be found running the hills of St. Louis's West County. Glenn, welcome to the session.
Thank you. Can everybody hear me?
Yes, no problem at all.
Okay, great. Well, thank you very much for the opportunity to speak to the Formfast group, and thank you for that very nice introduction. I have an opportunity to share with you a little bit about what our company does, but hopefully to give you some very practical ideas on how to make sure that you can apply revenue cycle improvement in a very practical and immediate fashion for your hospital. So I'm going to move forward very quickly with the first, there we go. Basically, in the recent March publication in Moody's, they kind of say it all. Healthcare reform pressures not-for-profit hospital leaders to adopt multi-year strategies, and I would even add multiple scenario strategies to make sure that you're ready for the wiggles and twists of healthcare that are coming. And the challenge isn't just with the recent healthcare reform, as we'll see in a little bit. It is ongoing and has been sustained for several years. We are fortunate to be healthcare providers, the hospitals, and with those healthcare providers with the recent healthcare reform, we're excited to know that there's going to be 32 million more people covered. And that's exciting. There will be subsidies for, there's a question about the subsidies that you enjoy currently for those that are in the federal poverty guidelines, funding exchanges to small businesses, no more pre-existing conditions, and there'll be a mandate for coverage for all. So in the short run, as this is phased in, hospitals will enjoy more people with coverage, and that will be a great relief to the uninsured burden that we have all been experiencing in healthcare. However, the squeeze is on, and somebody here in this office thought this was me, but the question I have is, who is that foot? And I think sometimes it feels like that foot is the government. Sometimes I think that foot is the insurance companies. Some of you might think it's your hospital boards or possibly your CEO. But the challenge is on really for profits, because even though there will be more coverage, we will continue to see decreases and limits to increases in Medicare and Medicaid. Medicaid will expand. But Medicaid currently only covers about 30% less than Medicare. Medicare claims to cover hospitals' costs, but oftentimes most providers are indicating that it doesn't do that. And then in the process of all of this change, the physicians are very concerned. Each month they keep prolonging when will the reductions in healthcare payments from Medicare to physicians be coming? Is it next month? Is it the month following? So we are seeing many of our hospital clients receiving new physicians who are eager to get a solid contract, and the hospitals at the same time are unsure as to how that's going to affect their bottom line. The squeeze is also on from the standpoint of the assumption in healthcare reform that there is an enormous savings to be enjoyed, and of course that is expected to be on the backs of you, the healthcare providers. 149 billion was the last number I could find, although this is a moving target. There's an expectation that that'll come from reduced costs of services and reduced reimbursement to hospitals who are currently getting paid for things that, from a quality perspective, maybe we shouldn't be getting paid for, like hospital-acquired conditions, readmissions, etc., reductions in disproportionate share. And behind all of this, with more coverage, is the threat to the nonprofit status that, given the fact that there will be less uninsured, we expect that, that question will be there: why aren't you paying property taxes, income taxes, etc.? You, as hospital leaders, have been challenged always, and I've been listening to some of the Formfast tools that are offered to look for savings. And those savings, I say, are nickels compared to the many millions of dollars that it takes to run a hospital. But all of the nickels add up. And you've had to look at staffing cuts. You've had to look at the best, most optimal ways to right-size healthcare. And then in parallel to this, to be looking to make healthcare even better. And so one of the things that challenged me as a former hospital CFO was that there's almost only so much reorganization I can lead or accomplish without simply getting paid more correctly and more fully for the services that we provide. So the fervent question on everybody's mind, and this is the healthcare financial leader who's pulling on his face here, is are you paid right? And most honest CFOs will look at their shoes if you ask them that question. And why do they not look at you in the eye? Well, it's because it's extremely complex. And there are so many handoffs and so many steps. The algorithms for how to get paid correctly, the pace of regulatory change, the complexity of regulations. I was in a meeting last week with cardiologists and looking at just a simple designation of what is an E&M level. And quite frankly, it's a Rubik's Cube to make that judgment. There are so many variables, and to explain to cardiologists what they have to document and how that comes together is just amazing to see what we've created here in order to receive proper payment. For hospitals, physicians, paper, computer systems, and people all have to come together, and the Formfast systems are helping to make the paper less an issue, but they all have to kind of come together in alignment to make sure that the care that was provided is actually the care that's documented, coded, charged, and ultimately billed and paid. And that sounds simple when you're outside of this industry, but I'm sure everyone on this call appreciates what a complexity that is and how easy that is to make a mistake, even with better computer systems. I wanted to share a little bit about the G2N process and how that process could be integrated into your hospital. And we have a very typical, when we do revenue cycle consulting, we like to offer assessments, and from that assessment, perform a more detailed analysis, assist with implementation, and then also validate that any changes are functioning as designed. So some of the key areas that we focus on for hospitals is outpatient charging. Outpatient facility charging is significant because that's in emergency, surgery, and radiology where the lion's share of complexity resides, and also where the opportunity for that error occurs. And I know if I were to have an ER visit with chest pain, I'm glad to know that the clinicians first care about my chest pain and second care about reimbursement. But unfortunately, we have to care about both in order to run the organization. So it is an ongoing challenge. Just a little bit about the assessment process. What we do and what we would encourage hospitals to do is to find the cycle time, the people, or the assistants to perform a bill audit, a review of their revenue and usage for the area under consideration, to review the related charge master items that relate to, for example, the ER or OR, and then also an analysis of the charge process. And that process isn't just the ultimate data. It's to look at the initial paper, hopefully not paper, maybe Formfast tickets, look at how that process follows all the way through to the bill, look at the other coordinating elements that may or may not be evidenced in the medical record, and then ultimately what lands on that bill and adjudicates out for proper payment. That whole process should be reviewed by somebody typically who doesn't own that process. What you find in all organizations, hospitals included, is when we're in it too deep, we just don't always see things clearly. We were told this is how to do our function. We do our function very well. And over time, those needs change, and people don't realize how those handoffs come together and don't come together. So now we've entitled the presentation today a forensic review, and I like that analysis. I found myself listening to and watching a lot of those crime shows that get just too darn scary. But I also find sometimes reimbursement for hospitals is also somewhat scary. And so the analogy works well for me that you really have to go a little deeper. And you can't just look on the skin, you must look under the skin of the process in order to make sure that everything is done properly. The case that we're going to be talking about today is an example of a blinded case from one of our clients. And I think it's a good example to show you because it's a sole community hospital. It's a small hospital. It's critical access, which means the inpatient census is not large. They pretty much, their bottom line is defined by their outpatient services, ER and OR in particular. This is a small hospital with total patient revenues of $70 million and a 1.5% profit, and close to an urban core. So what they really do is care for those patients in that area. The OR volume is defined on this slide along with the percentage of OR to the total. 20% of the hospital volume is comprised by this single department. You can see there's just a small number of OR rooms available. On the charge capture process, what you have here is something that we find, I would say, different at every hospital. But in this example, the clinical staff completes charge sheets. I believe it was paper. The night shift enters charges. The HIM applies procedure codes, typically maybe several days later. And HIM also identifies missing charges and really attempts to reconcile the case during the coding process in order to facilitate the bill. So you have a little bit of a complex process here with several different parties at different times of several days in order to get a single case properly billed. This hospital did have a revenue cycle team, and I would imagine most of the hospitals on the line today also have a revenue cycle team. This particular one met monthly and covers a wide range of issues, included a lot of the key stakeholders, including HIM registration, billing, compliance, etc., and invites clinical managers as needed. A patient advocate is also available at the hospital to deal with complaints and payment issues. The designated compliance officer performs regular documentation bill audits, and those bill audits are reported out on a regular basis out to the leadership team. One of the problems sometimes with hospital compliance processes is they can become rather integrated into the way everything else works at the hospital. So one of the problems is that systems can be in place to identify issues, but little maybe is being identified, and that was the case here, and very little is being addressed. The revenue cycle improvement requires a critical eye and constantly seeking new information. I mean, I think it's a fair assumption to say that something is awry at most hospitals. The question is, how do we find that? What's the best way to make sure that we can extract that and keep ourselves not only out of trouble with the government, but to make sure that we're getting paid fully? In addition to this hospital well-utilized external resources to file a proper cost report, to have their charge master reviewed. One of the things that I did identify, and this may be the case at some hospitals, is the charge master review is oftentimes an electronic process, and this was done on a quarterly basis. But one of the problems with electronic only can be that the descriptions are not fully understood. And those of you that are close to the process may realize that a description may not properly match its related code, and over time, in a particular hospital, those descriptions kind of grow an understanding of their own within that hospital, but no longer make sense to what the current descriptions are for the regulations. So it's very important that a line-by-line review is done, the conversations occur with clinicians to make sure that those line items are accurate. And then coding audits were also provided by an outside firm. So this is an organization that had some external activity going on. This slide shows you their payer mix. And I think that the one comment I want to make is we see in the hospitals that we serve in various markets a wide variety of payer mix situations. It's always great to see insurance at 41%. It's even better if you can see that that insurance pays you a percentage of charge. And the 41% of insured business in this hospital paid 80% of charges, excluding, of course, United Healthcare. So for those of you that are close to hospital finance, you pretty much live and die on the bottom line based upon the compensable reimbursement that you receive from percentage of charge patients. Hospitals that are not in urban centers typically enjoy a higher charge percentage ratio. This widely varies state to state. But that was their case, So the good news for that is if you find a dollar, 41% of that business at 80% would be hitting your bottom line if you found an opportunity. So continuing with the crime scene example here, I think underpayment is a crime. And the question I have for you, this example that we're going through is an OR example, but in the world that you're in, do you happen to wonder or suppose, where your crime scene is? It may not be the OR, it may be some of these other areas. I'm going to jump right to some of our findings, and our findings were the findings of the audit process. What we discovered in this OR for this small hospital was that facility anesthesia was not charged, surgical recovery services were not charged, which is a very legitimate charge for surgery cases. And then CPT codes with multiple procedure CPTs were not appearing in the patient bill consistently. And then there were oftentimes 0 units appearing on a patient bill when multiple procedures were being charged, multiple CPTs were being charged. You can see the frequency was very high. So this was an opportunity for new net revenue for services that were assumed to not be compensable. In addition to that, there were audit findings regarding modifiers, and in some cases, these modifier findings have a dollar impact, modifier 59, and the replacement of 52 with 57, and so on. So modifiers are important also from the standpoint of what you convey out to the intermediaries and to the other government agencies about the frequency of activity. It could be suspicious if it's not well understood how modifiers should be applied, and if they're applied inconsistently, that may draw scrutiny to your hospital. Additional audit findings included drugs documented but were not charged. So it was great that they were documenting them, but they were not charging them and missing an opportunity, especially for that charge-based reimbursement. Glenn,
do you mind if I interrupt you for just 1 minute? I'm sorry. If you wouldn't mind speaking up a little bit, a few of our listeners are having a tough time hearing you.
Okay, let me just move a little closer. Can you hear better now?
Definitely. Thank you very much.
Okay. Sorry about that. So basically, we also, on this slide, are seeing incorrect drugs were charged not according to the documentation. The J-code description for units did not match the billing units, etc. Facility charging, this is a kind of a unique finding here, but the charging process for inpatient surgery was very different than the outpatient surgery. And in this hospital, you could actually pay more for your colonoscopy if it was done inpatient than you would if it was done outpatient, which is incongruent with the cost structure of caring for the patient on an inpatient basis. So typically, G2N and most of the philosophies and guidelines that we follow try to follow a logic of aligning your charges with cost and making sure that the patient bill is logical inpatient versus outpatient. Additional audit findings identified that professional anesthesia, the professional anesthesia was subsidized by the hospital, which is typically the case in many hospitals, and they were actually not getting reimbursed to cover the cost of the anesthesiologist. And in looking at the anesthesiologist's reimbursement, it was very clear that the charge processes had not been updated for, I think at this time this was a good 7 years. In addition to that, the amount of Medicare volume wasn't consistent with the hospital's volume. So it was very suspicious to understand that the professional anesthesia reimbursement was far lower than it would appear to be logical to receive. So that represented another opportunity. One of the things that's unique about our process that we recommend and that we use as a company is that we feel like it's very important not only to look at audit information and data and reports, but also to talk to the people. The people involved in healthcare will help you understand what they're doing and what they're maybe not doing, and that helps to also identify where the handoffs might be missing. And so through the interview findings, we realized that there really was no charge reconciliation process for surgery. It's a challenge in all surgery departments, but it really was pretty far off for fundamental issues in this particular hospital. The charge process, as I indicated earlier, has many stages, and whenever there's a situation where there are many stages, those are opportunities for the numbers to be missed, for things to not be tidy. Existing HIM charge capture revealed a magnitude of surgery opportunity, and we'll get into that in just a little bit. The process also for charging for implants was very cumbersome and did not capture all units. And implants, most people understand, can be kind of a challenge. Sometimes you have hospital contracts that require you to present implant invoices one way, and on other contracts they cover them another way. So the process was very one by one, and what we identified is that in many cases they were not properly billed. In addition to the interview findings, we found that the supply markup ratios were inconsistent. Most hospitals are charging supplies on the basis of a markup that starts at a very high multiple. For example, you may charge something that costs $5 at $25. But when you get to something that costs $1,000, you may only charge $1,200, something like that. What we saw was an evolution of charging that had been evolving for many years and had no relevance to logic, and it just made no sense at all. So that was a finding. And some of those findings aren't necessarily net revenue related. They're more, let's make sure that things are tidy so that your bills make sense. And that's becoming more and more an issue as we move forward with a lot more transparency in healthcare. In addition, no cash was collected at the time of service, which was an issue just for making sure that you could optimize your reimbursement. And the hospital also had several revenue cycle initiatives that were planned, and so that was nice to see that they were planning to move forward with cash collections, but that had not taken place yet. Their charge master maintenance was also supported by an external review, and however, the regulatory updates were not being updated on a consistent basis. And it was clear from our interviews that the clinical managers really didn't understand their sections. And hospitals large and small, this is a really common issue, very, very challenging because the regulations are complex. Most clinical managers care more about the clinical work that they do, which is great. But unfortunately, they're also obligated to help understand that they're selecting the right items and that their charge master is working well for what they're doing, or they're not really doing their jobs to manage their section of the revenue for the hospital. This is one of my favorite slides. Charging is nuts, and it comes up really every day at G2N. Those of you that have relatives outside of healthcare probably share stories about how crazy their healthcare bill looks. And I would agree. If you were going to go buy a tire for your car, I guess that's the tire that I need for my car. In my area, there's maybe a 20% variance on what that tire would cost. And most people would understand that if you shop that tire well, you might be able to get a fairly good deal. But a 20% variance makes sense. This slide might be more difficult to look at, but it's a mere snapshot of the kinds of pricing scenarios that we see as a company. And you see in this example that you have some high-frequency items like a CBC blood test, which is the third line item down. The charge in this example was $20.50, but within the compare group of this hospital, you see a 220% variance in healthcare. So it's really difficult for the public to understand charging, and it will be a long time before charging is logical and simple because of the fact that we live off of that percentage of charge, and most hospitals are not willing to reduce their charges from that. I bring that up because for a long time now, we know that Medicare, Medicaid, and many of your insurance plans are not paying charges. However, that charge sensitivity does drive your reimbursement. At this hospital, the high charges that they were seeing in the surgery department were creating patient complaints, increasing the amount that patients had to pay as copays, and was creating a lot of ill will in the public. And this was why they're in this particular hospital, they had a policy of setting their charges at 96th percentile, which no hospital that we're aware of ever does. It was just kind of a statement that had been made in a process that was followed. But it created a challenge for us because we like to go in and help hospitals find new net revenue. But in this example, their charges were high, and there was no way to help them with that particular problem other than to help them figure out how to lower those charges and make it more palatable across the high-frequency items that they use. Cataract surgery was the highest frequency of patient complaints. So I'll jump right now to the recommendations that we made and then share with you a couple of fixes to that process. Our recommendations included aligning the charge methodology to make sure that there was one charge philosophy for the OR, the same charges for inpatient and outpatient, so that there was an equity with how those charges would follow. We recommend that they streamline the charge process for all surgery cases to make sure that it's operationally easy, including implants, and consistent. We also recommended that they initiate a charge methodology to capture facility anesthesia charges that were not being charged. Additionally, we recommend that they initiated a charge methodology to capture revenue services for multiple levels of care, and that recovery services be discussed, and that service charge be added. We also wanted them to move a charge function to the surgery department, and that the surgery department would fully own the process of charging and capturing and reconciling, so that they would have that ownership for completeness. And then also to design and install a charge reconciliation process for the surgery department. And the final recommendations include the audit they audit the charge process for professional anesthesia for completeness, and reconcile that back to the cases in the hospital, and then to address the code issues to be ready for the RAC review. In our initial assessment, what we discovered on an annualized basis from the claims that we looked at and from the conversations that we had, and in looking at their revenue usage of frequencies, we saw that the opportunity for anesthesia improvement of net revenue was $150,000. Additional net revenue for recovery was $260,000. And additional net revenue in total from those two issues, not expecting any improvement for charge methodology, was $430,000. And this is for a very small hospital. So the process that we follow after this then kind of fits the typical consulting process here. We perform the analysis and the assessment. We move into analysis and implementation. And in the analysis, we look at additional records. We go into more detail, and we want to make sure that the hospitals fully understand, that we fully understand what they're doing, and that we fully have captured with a greater sample size exactly the scenario. Because if you're going to go and make significant changes, you don't want to do that with a small sample. And then what we do is conducted additional interviews. In that process, have been working with the team members to assemble an implementation plan, so it's very clear who's going to do what by when to address these issues, so that there can be a distinct go-live date for which everybody is involved in. And again, this can be done by G2N, but this can also be done by internal change agents, and that's why I share this process with you. It's also important that in order to lead this process, that there may need to be new templates, and Formfast is a good example of a company that can help set those up. And when we've done these in the past, some of those hospitals did not use a Formfast, and it makes sense that all of those new forms would be done, or change forms would be done through Formfast. Updates to the charge master must be done. That's the backbone of reimbursement. If there are things that are missing for reimbursement, that has to be performed. And additional education so that things are done properly. When we do this, we also have a full executive summary. We tabulate the value of the results, and we show every single claim that we've looked at. So it's very important for the team to see precisely what was wrong and what we're going to together do about it. And most excitingly, the financial impact, the potential for new net revenue. The next slides actually show you actual findings. And these findings were for each of these areas discussed. You see that there's a significant negative finding if we were to follow reducing charges for OR. They did not actually follow that, and most hospitals don't. Instead, we looked at a charge methodology change. You can see the positive increases of facility anesthesia, recovery, and certain incorrect payment items. For professional anesthesia, it was largely all positive, and you can see there was an array of issues spanning from missing remits all the way to incorrect add-on unit charges. Within endoscopy, we had issues ranging from incorrect payment, missing charging for recovery, and GI endoscopy charge method, and also some pharmacy items were actually a takeaway. the good news in this process is what we assessed identified $430,000 of net revenue potential, but what we actually were able to help them identify was a net improvement of $690,000, and that was even in realigning the charge methodology. Remember, they had set their charges extremely high. We helped them reestablish a charge philosophy that actually lowered charges and took away approximately $200,000. But in so doing, we added recovery charges, and these are net revenue figures, by the way, and restored charging processes for anesthesia. And in total, the net revenue improvement, net of those takeaways, was $690,000. So it exceeded our initial. Now, it's one thing to find opportunity, and I'm sure many of you have done that at your hospitals. It's a whole another thing. I know as a hospital CFO, making a change was the challenge, and getting everybody to come together and make that change happen. And so the implementation to me is the art, getting things to change and making them work, and using the tools available to make them work. And I think one of the terms that we use a lot here is operationally easy. If we can't help you make it easy, and I know the forms from Formfast and some of the other tools available help make that process easy, then it probably won't work. And so we're very keen on making sure that when we come up with an implementation plan, that we do it with the people involved, that we also integrate the ideas that they may have for the best plan. We want to not only get the shortest path from the finding to the fix, but we also want to make sure that it will stick. In this particular example, we had 15 findings that we just went over most of those findings in a broader fashion. Within those findings, there were 85 action steps, and I know that sounds daunting, but those steps could be simply breaking down the process of, for example, charge capture, redesigning a form, training on the form, testing the form, things like that. So there were 85 steps necessary. G2N did a lot of work to help realign the charge methodology, tumble the numbers to make sure that the revenue that was going to be realized from the new process was going to be as good as possible, but be far more logical than it had been before. There were 17 different owners in the process that included many different people in the hospital, including registration and HIM and finance, but also including G2N. And the implementation process was crafted in such a way that it could be completed in 45 days, which is very fast for those of us that work with hospitals. Now, it's another thing to go and make those changes and say it's working right. It's very important for us to also validate that it's functioning as designed. And so one of the things that we think is important if you do this yourself is that you don't trust that what you just did worked. And so what we do is basically we re-audit the new world approximately 60 days after live to make sure that the changes and the new processes that have been installed are functioning as designed. And so we did this process, and in so doing, we were pleased to see that the endoscopy unit was charged correctly 100% of the time. Outpatient surgery was charged correctly in the new methodology 100% of the time. Recovery was charged correctly on almost all claims, but there were a few issues, and we identified what those issues were and helped this client rectify those issues. And that's actually not uncommon. As you can appreciate, when you're putting in so much change, you may find a few things slip. Anesthesia charging was in place on 100% of the claims reviewed, and the CPT codes and charges were correct. And then the pharmacy charges were correct on 93% of the claims reviewed, and the unit still needed a little work, only on 73% of the claims reviewed. So it's an example where when you go to this complexity and attempt to correct it all, you need to validate, and in some cases we've had clients want to revalidate many months later because they know that the people, the systems, and the processes can be offended over time by the fact that we all kind of tend to go back to our old ways. But ultimately, the validation results did confirm that the hospital is realizing the net revenue value of $690,000. The hospital will continue to review the charge capture process and surgery and monitor the results to make sure that they're holding their gains. This particular project, when you realize $690,000 on a hospital that had a 1.5% bottom line, represented a 70% increase in their net operating net income. That's substantial, and that's the thing that is available for many, many hospitals, but you have to consistently have that critical eye and to be looking under the skin of your operation. Now, you have a different hospital. Many of you are from larger hospitals and systems and may not have complete ownership for some of these different functions. So it's not uncommon to find millions of dollars or only $700,000. What is almost never found is just a little bit. And I think that's the challenge right now with healthcare, that it's that complex and challenging that you have to have a process in a revenue cycle function to keep looking and finding new net revenue. Just a quick couple of slides about G2N, and then we'd like to open it up for any questions. We're eager to answer any questions. G2N is always eager to help our clients with the pursuit of net revenue, but always within the context of an honest and healthy bottom line. We help hospitals become more compliant, but we do find that hospitals generally are underpaid, that the bulky processes keep them from getting paid fully, and that net revenue opportunity does exist. The net revenue, and a lot of the folks that were on the earlier discussion with Formfast, the net revenue available to hospitals is throughout this revenue cycle on the front end. G2N space is largely in this green area that is in care documentation, charge capture, and coding. But it can be anywhere along this spectrum that you may miss net revenue. It's so important that net revenue is realized, because once you send a bill out, the poor business office just has to do their work over and over again to try to discern how to push that bill through when there have been a lot of errors on that. Our firm offers the charge capture reviews that we've been discussing. We do a whole lot of coding for hospitals. We also do a lot of charge master related work. And we also work with our clients on a continuing basis to keep them current with charge master and charge capture issues. Again, most everything that we do as a company comes back to net revenue increase, compliance risk reduction, process improvement, and hopefully a sound return on investment that is always honest and healthy. So I tried to keep it brief and keep this case study relevant, because everybody's situation is different, and I think that's important to identify. So I guess I'm opening up for questions.
Excellent. Glenn, thank you so much for a tremendous amount of great information today. We haven't had any questions come in. However, if we do have any of those questions, we'll make sure that we get together with you so we can reply back accordingly, okay?
Great. Well, thank you very much for the opportunity.
You bet.